Very much. I've got a fairly broad remit with this, and I have to confess it is a slightly sort of self-indulgent journey through my sort of African experience. And I'm kind of going to start at the end and then go back to the beginning again. At the moment, I am the chairman of a charity that I founded that is currently responsible for the healthcare of 1/3 people. This is the total healthcare in Zanzibar. And what I want to really explain is how me as a urologist has ended up in this position, and how very important Urolink has been throughout that process. And in fact, there is no question, and I'm not just saying this because I'm in a Urolink meeting, there is no doubt at all that I would not have done this were it not for Urolink. So although what I'm going to say, some of it, particularly towards the end, doesn't involve Urolink now, it's happening because of Urolink. So to sort of go right back now, it kind of all began, the whole Africa thing began for me. Can you hear me if I move away from, yes? Began for me when I was an elective student, and that's why we encourage elective students now within our own project. I went away to Mombasa and worked in the Coast Province General Hospital. Absolutely loved it. Spent a lot of time actually, to be honest, not working, but just soaking up the Africa thing, and just completely loved it from the very beginning. And that kind of got me going. Then came Urolink. I was a young urologist, and I bumped into Neville Harrison, who was the founder of Urolink, and is a bit of a sort of legend amongst us Urolink people. And Neville persuaded me to go to KCMC, that Dom has given a very nice description of. And my subsequent Urolink experiences, as you see there, I was a committee member from 1998, and then I was the chair for quite a number of years, and followed then by Susie. So for me, KCMC was a game changer. I worked with Lester, who Dom has also discussed. There's Lester there. He was an incredible character, and set up the unit, as Dom has described. And Urolink has had involvement with KCMC for 30 years, and still it is one of the 3 centres that we support, along with Lusaka and Hawassa. For me, as a junior registrar, it was fantastic. I mean, I learned a lot of open surgery. I was doing a lot of retrograde prostatectomies. The pathology was incredible. These are 3 bladder exstrophies on the ward at one time. Schistosomiasis, there's a stenosis of the lower third of the ureter there, really common. There's a VVF clinic, lots of fistula repairs that we got up to. 4 patients there, all with VVFs. And just learning another way of doing things. I mean, they used to make, well, still do actually, make all their own irrigation fluid, for example. Make their own lubricating jelly with coconut oil, and just improvisation. And it makes you understand, actually, that we are very fortunate here to have what we have. But it is possible to make do on a lot less. This is a cystectomy patient, a young patient with schistosomiasis, squamous carcinoma of the bladder, no stomas. So we had to use gloves as a stoma bag. And then probably the scariest thing that I've ever done in my whole life, I was asked to go on a flying doctor visit. And, I was a junior guy, and I could do TURPs, and I could do sort of scrotal stuff. And I was up for it, and off I set on this little plane on my own. In fact, there was an orthopedic consultant, the surgeon, but he was dropped off halfway. And I ended up in this place called Shirati, which is right on Lake Victoria. And I literally had 2 suitcases with endoscopic kit and the bits and bobs that I needed. And it was really scary. And I'd turn up, do a clinic, then operate, then another clinic, then operate. It was completely crazy, but even now I get slightly anxious even thinking about it. But it was great, and just a fantastic experience. And then on the way home from KCMC, I stopped in Zanzibar, where I met Mohammed Jadawi, who has been pivotal to the whole of my subsequent involvement in Africa. So that's my daughter, who's now 29. That's her, 28. That's her then in 1994. She came with me on, and as did my second child at that time. So I worked for a month then in Zanzibar with Mohammed Jadawi, who was the only surgeon on the island. And at that time, Zanzibar was just over 1 million population, terrible healthcare system, basically. Virtually no urology at all, although Mohammed, who is there, had been in Brighton, actually, and had trained under Phil Thomas and a few others in basic urology. So Mohammed and I then established the urology service in Zanzibar, which is existing now, and it's a fairly good service now, run actually now by Chinese urologists. But it works. And that was supported for 5 years by Urolink. They were key at the very beginning and helped us establish that urology service. It then sort of goes away from Urolink into the rest of the stuff that I've done. Pivotally, Mohammed Jadawi became Principal Secretary to the Minister of Health. So he then was in a position of power. And we literally sat in a bar one day in 2007, the Sunset Bar. And we said, what are we going to do now? What can we do that's going to make a difference in a more sustainable way? And Mohammed suggested that we take over this hospital here, this hospital here in Makunduchi. There, I can't really see the pointer, can you? It's there. Essentially, the healthcare system on Zanzibar then and now, obviously it's now about 1.5 million, but then 1.3. Healthcare provided within 3 hospitals, 2 district hospitals, one in the south, Makunduchi, one in the north, Kivunge, and then Nazimoja, which is the dysfunctional sort of tertiary referral hospital in the middle there, which is in the capital. Then, in 2007, the whole lot was dysfunctional. These hospitals were virtually not working at all, no doctors, staff that didn't turn up. So there was no healthcare here or up in the north. So everything poured into Stone Town, which was equally dysfunctional. So really terrible healthcare provision. So, and that with obviously the figures to go along with it. 1 in 183 mothers dying in labour. Just to put into context, this is a BMJ article at that time, 2007 actually, and it talks about the waste of money put into Africa up until then. And if you see here, it says a total of $2.3 trillion spent on development aid over the past 5 decades with almost no change in outcome. And what they're saying here, he's the author of this book, White Man's Burden, contends the entire aid setup is fatally flawed. Essentially, and he was right, money was being given to governments and being misused. And the advice was, don't give it to governments, take it out of their hands and get in on the ground and where you can see what's going on and you can target your aid effectively and be useful. And that's essentially what we did. So there I am, young-looking me. 2007, we signed a contract with that's Mohammed there, and that chap behind is the Minister of Health, or was. Signed a contract to take over the running of Makunduchi Hospital. And this was the sort of really crazy bit. I mean, there was I, as a urologist, consultant urologist, signing a contract to take over running a hospital. And thinking about it, I just wondered what on earth I was doing. But we just did it, and it's because it couldn't get any worse, really. And we didn't really know what we were doing, but signed it anyway, had a few ideas. And so the contract basically was a 10-year deal where the government gave us the hospital, they supplied the staff, they paid the staff, and they gave us autonomy to change things and to run it within their system, but we were allowed to make changes. And we set up then, consequently, the charity, Health Improvement Project, Zanzibar HIPS, was registered that following year. So off we set, and so that's Makunduchi. Then obviously very rural. This is the main hospital is actually here, and these are the accommodation for the staff. That's as it was in 2007. And the kind of HIPS model is actually to improve the provision of healthcare in initially Makunduchi, and then we hoped in Kivungi to make sure these hospitals drew in the people that lived nearby. Population down here around 100,000, up there about 250,000, taking the pressure then off the main hospital. And that was the kind of model that we were aiming to work to. And then we would do it in this way. Most importantly, staff are the absolute complete key. You can make pretty buildings, but if the staff don't work, the hospital doesn't work. So I'm not going to go into the detail here, but basically managing the staff in the way that we said there, and very importantly, changing the systems and the processes. And we had no money, really no money at this point, which was kind of a good thing because we had to be very frugal, but we couldn't throw money at it. We had to make fundamental changes working with the government, which is what we did. And then according to need, we then bought equipment and changed the infrastructure as well. And as a consequence of that, developed the clinical services. And it worked, and I'll come back a wee bit about some of the outcome measures, but essentially then we were asked, this is the president here, to sign the same contract for Kivungi in the north in 2012, which we did. So this is the picture that you saw at the beginning. So here we are now, 360,000 people serving these two hospitals. And it's kind of worked, really. I mean, there's many, many problems, but it has fundamentally worked by and large. And what I'm going to do is very quickly whiz through the sort of key things that we've done, just nice pictures, and it's quite a nice story. How long do I have, guys? 10 minutes? Yeah. We built two primary healthcare units, one in the south, one in Kivungi, one in Makunduchi. Very important, because these hospitals, when we took them over, they were just totally dysfunctional. So everything was going on all at once, primary healthcare, secondary healthcare. It was chaos. And this wasn't our model, actually. We copied this. So we built these two big primary healthcare units, sort of 100,000, 200,000 pounds each, to take away all the primary healthcare services so that the main hospital then functions as a proper secondary healthcare environment, and we redesigned how it all worked. So we did that, and these two units are currently treating in excess of 100,000 patients a year, the ones that we built. We were very specific about what we build. We're very careful about it. We tend to renovate rather than build new, and we build according to need. And I won't go into all that, but we have done quite a bit of building, but it's expensive. Building is expensive, so it's not necessarily what you should do if you can avoid it. So we tended to enlarge, renovate, rather than build anew. Equipment, again, very targeted. The key with equipment is target it properly. So buy equipment only that you need. Make sure that it's appropriate for Africa, and make sure you can repair it if it breaks down. Those are the absolute key things. And in terms of the appropriateness for Africa, for example, the anaesthetic machines, we use the Gloucester vent anaesthetic machine, 12,000 quid. The main hospital in Stonetown littered with these £100,000 anaesthetic machines that simply don't work. They break down, they can't repair them. Gloucester vents, absolutely bulletproof. They're perfect for Africa. And this is the Sonosite ultrasound machine. Again, perfect for Africa. You can drop them on the floor and they still work. I'm not going to really go into this. Is just a couple of nice pictures of how things have changed. That's actually the maternity suite as it was in Makunduchi. The single there with two doors right next to it. That's where the women were delivering. And we rebuilt the unit. So numbers, there were no doctors at all. Few clinical officers in the two hospitals. Now, largely due to lobbying the government, proving that these hospitals are working, we've now got this increased level of doctors and AMOs, not actually nurses. That's still a real problem. But we have a lot of doctors now in both the hospitals, which has completely transformed the way that they work. And we've established a load of services. None of this stuff was happening before. So we've got all those services there. And the key is we also supplement those clinics with public health education. We make them regular so the population know when they're going to happen and they turn up. There's no system of appointments. Prescribing is much better according to guidelines now, and the drug availability, the government provide the drugs. We supplement the key drugs when we absolutely have to, but we try and make it all sustainable. Staff training, utterly important. Obviously, there's no point our doctors doing all the work. The key is to train the staff so that when we're not there anymore, they're able to manage. This is the lovely Philomena, who's now manages one of the hospitals, and we support her right from the beginning. Dental health, there used to be only extractions. Now there's restorative, fillings. Really important. Children losing their teeth now doesn't happen. That's not quite true, but it happens a lot less often. Surgery, that's the Gloucester event there. You can just see it on the left. That's Fatawi. He's the chap we trained as a nurse anaesthetist. In fact, we trained 4 now. We could do better with surgery. We have increased the numbers. It is an area where we need to still improve, but it's better than it was. So when you go back to your hospitals and you complain about how terrible things are, that's actually KCMC, Dom. This is not Zanzibar, but it could be worse. Love that picture. We set up, this is the hardest thing we did, we set up a comprehensive maternity service in both hospitals. And this is Amor, he's our amazing doctor. We incentivize him, we give him additional money. And this is Amor doing a cesarean section. There were no sections ever in these 2 hospitals until 2011, I think was the first one. And we're now doing, in fact, more than that now, actually. And that's important because these people would otherwise be traveling to the main hospital and their care was pretty poor, is pretty poor. So it definitely does save lives. This is the figure I love. This is when we started in 2007, the 2 hospitals together were delivering between 40 and 50 babies per month. In May of this year, we delivered 525 babies in Kivunge and whatever the rest of that is to make it 704 in Makunduchi. These mothers were previously delivering in the community with obviously disastrous consequences. So it just, people are traveling to these hospitals, and sometimes from Stone Town actually to deliver in our 2 hospitals. And maternal mortality has plummeted in our, as I say, it was 1 in 183, and last year only 2 mothers died in our hospitals. Big unit being built. We're not funding it, actually. This is a great big, nearly $2 million unit built in Kivunge. Again, I think because it's working, the hospital, it's attracting the money from overseas. We are organising this. We have designed it, and we are also organising staff rotas and the equipment inventory, which we've in fact done already. And that will open sometime next year. Another picture I absolutely love. We set up kangaroo mother care, which does work for low birth weight babies, because there's no intensive care units, no neonatal units, and it reduces mortality dramatically. In fact, we had a 900-gram baby that survived in Makunduchi about 3 months ago, would never have survived normally. And we built their standalone buildings for the kangaroo mother care. Malnutrition projects. Malnutrition is a big problem in Zanzibar. Although it being a beautiful country, it's still got all the same problems that Africa has elsewhere. Burns, we've got a big project funded by the Festival Medical Services, who do all the doctoring work for Glastonbury and us. We are their main charity. And burns are very common in Zanzibar for open fires, alcohol, poor supervision of children, etc. And we have a very coordinated project actually now going through that's working very well. We have a Comic Relief funded mental health project now. We're in year 2 of that. It's all based in the community. Mental health, real problem, major issue. And this project actually going very well. We're just applying for more Comic Relief funding now to to extend it throughout other districts. This slide is kind of important to me that what this is kind of saying here is that affecting change in Africa is extremely difficult, and affecting change that is sustainable is even more difficult because so many factors are involved. And I'm supposing you put cesarean section in the middle of that. You know, you need to train the staff, you need to get the patients of visiting coming to the hospital trusting it, you need to train the midwives, you need to have the doctors, you need to have the surgeons, you've got to have an ultrasound machine, you've got to have blood transfusion available, etc. And none of that was really around, and everything has got to work for C-sections to happen. So if your blood fridge breaks down, you can't do a C-section. So it kind of illustrates that everything's got to work, and it's not easy to do that remotely. And that's why being embedded in the hospital is so important. Electives that I discussed before, really important. We've now got, in fact, it's nearly 100 students have come for periods of time, and they have a brilliant time. Volunteer doctors, we've now had, I said 37 there, maybe slightly more. These are UK, generally speaking, UK trainees, usually around post F2, CT2, CT3. So they're experienced enough to contribute and be useful, but they're not kind of tied, so they're generally not married, they've got no mortgage, they're able to stay, and they have to stay for a minimum of 6 months. And some of them, and Nick in the audience here was there for over a year. And it's a hell of a commitment, and they have an incredible time. And many of them, like Nick, are involved, trustees, involved in the various areas that we're doing. It's a fantastic thing. So 37 UK doctors spend over 6 months working here, and it changes their lives for some of them. Obviously, to make this work, you need a big team of people in Zanzibar, and it's expensive to keep that all going. In fact, it's bigger than this now, but we have lots of people out there who we pay, we give a salary. We sign new contracts now with the government because the Makunduchi ones run out, but we're making it sustainable. The government are taking on some of the functions that we were doing. They're paying for the managers, for example, and doing various things. So we're trying to exit slowly from both hospitals, but we are committed till 2023. So the money, to make this all work, we need £14,000 per month, which is actually amazingly cheap, really. It's a struggle to do it, but given the reach, it is incredibly cheap, really. And it's really down to, because the volunteers are all free, we don't pay a salary, but we obviously got to fly them out, we've got to accommodate them, so we've got houses out there, cars, and supporting the staff that we pay out in Zanzibar. And almost all the money is spent in Zanzibar. And we've raised just around about 2 million quid over the last 10 years. And that's kind of the breakdown of how we've done it. But it is becoming increasingly difficult. So that's it. And it's really, for me, Urolink was the key. And I encourage any of you out there who want to do this, give it a go, because you never know quite what's going to happen and what it'll end up like. That's it. Done. Thank you.
Thank you, Roo. That's absolutely perfect. And to time. We probably have got a second for any questions from the audience, I'm sure. Anyone got any burning questions for Roo or Dom? Fine, I'm sure they'll... Oh, sorry, Charles. Is it Charles?
Set up those health services in Zanzibar?
I think we are certainly we're massively risk averse I don't know whether you went to the talk earlier on today. We avoid all risk. Obviously, this is a risk that we wouldn't accept, but I think we throw money at things so much in the UK, and you can do things a lot cheaper and very effectively. they can certainly learn a lot from the staff. Some of the staff are so committed.
I think there's an acceptance that the NHS has got a lot to gain from involvement in overseas projects directly as well for their staff. We've been very much pushing that at our trust, and I think everyone can do it at their own trust. There's a lot of gain for the British hospitals and the staff.
And completely key, people like, it's great to hear Dom talking today and being so positive about it. It's important to get as many junior doctors out there as we can, because you don't know quite what will then happen to those people and you know, what good they might do going forward. So we should involve juniors with everything we do.
Wilson, so North London trainee. How did you, obviously it's an incredible amount of work and well done, how did you manage to fit that in together with the work at the NHS as a consultant?
You better ask Mr. Speakman, who's my colleague. He covers me all the time. I guess I just love it, and I do it in my spare time, and I'm not on my own. Obviously, we got a fantastic, amazing team of people, trustees, volunteers, amazing team in Zanzibar. So it was harder, but I think now that you know, everyone's contributing a lot more. Once we kicked it off, you know, it now doesn't run itself, but you know, the duties are very split, and I have very supportive colleagues, you know, without doubt, which does make a difference. Unfortunately, Mr. Speakman's retiring, so.
Drew, I have a question. Sorry, is there?
Yeah, I've got a question. Hi.
Yeah, go for it.
My name is Ahmed. I'm a medical student. How is your work, relatively successful work with the two hospitals? How has that affected the main hospital in the capital city?
It's affected it hugely, actually, in two ways. One, because there are less people going there. And two, because they have used us to pilot certain things. And there's lots of things I haven't told you there. For example, we have biometric thumb printing attendance, which we started because the attendance was very poor. So we now have everyone who comes to work has to thumbprint. So we know when they're coming in, when they're late, when they're absent. And now they're doing the same thing in the main hospital. A lot of the practices that we've started are now being copied by the main hospital. So, I mean, we'll never be able to take over that hospital. It's just too big. But so yes, they're less numbers, and they've learned from what we've done successfully.
Drew, I had a question. I mean, you've changed lives globally and in Africa, and in a different context, you're also very much into research and, you know, improvement. And do you see at some point in time in the future, I mean, we've got some amazing initiatives with BURST, and I can see some of the BURST members in the audience, for trainees to, I mean, is this something that could be looked at in the future for real life statistics and research through Urolink?
Definitely yes, but it is becoming more difficult to do research, as I'm sure you know. It used to be you could almost do whatever you wanted, and now, quite rightly, you've got to go through significant hoops, ethical approval and all the rest of it. So yes, if you've got the contacts in the countries, definitely tapping into that. There's incredible pathology, large numbers of patients, but it has to now be done in a very organised way. You can't just pitch up there like we used to, like I used to, collect data and come back and present it. I mean, you can do it on a low level, but you've got to do it properly.
So that, no doubt, will drive change and improvement in its own self.
Yes. Yeah.
Okay, well, thank you very much. If there are no other questions, it's been an amazing journey. And once again, thanks to Drew and Dom. And